can start.
So, good evening, everyone, and welcome to the second session of what we call it as EPIC, that is Endo-Physician Interconnect meeting. And we are on a series of topics on adrenal medicine. This is the second of the series. The topic today is extremely relevant to the current situation. You know, we are all in the midst of a pandemic. We're in midst of a COVID-19 pandemic. We're also in midst of a mucormycosis epidemic and an epidemic of acute hyperglycemias, epidemic of steroid-induced hyperglycemias. So I think this topic couldn't have come at a better time. I think this is absolutely perfect timing for this topic. And let me assure you, we didn't plan for this, but it's a great coincidence that we're talking about exogenous Cushings before we are going to see a long list of patients with exogenous Cushings in practice. So as you are all very well aware, this series is basically chaired by Dr. Sanjay Kalra, Dr. Ganpati Bantwal sir, and Dr. Rakesh Sahai sir. And I'm Dr. Om Lakhani. I'm an endocrinologist from Ahmedabad. So today, our speaker, I'll introduce the speakers and the panelists today. So just to give you a brief, we are going to start with a talk by Dr. Saurabh Arora, and then it will be followed by a discussion where we'll be introducing the panelists as well. Yeah. So our speaker today is a young endocrinologist, Dr. Saurabh Arora. He's done his DM endocrinology from BHU Varanasi, excellent institute for endocrinology. He's currently assistant professor in the Department of Endocrinology at Dayanand Medical College and Hospital at Ludhiana. He has 8 excellent publications in both national and international index journals. He has presented papers at both national and international conferences. In fact, he has an excellent paper on early detection of lipohypertrophy in insulin injecting patients with diabetes mellitus, which was presented recently in ADA 2020. He's an investigator in 4 major clinical trials. His primary areas of interest include primary hyperparathyroidism, obesity, local complications of insulin therapy, and so on. So this is Dr. Saurabh Arora. I'll also quickly introduce the panelists. We'll reintroduce them when we have the Q&A session and the discussion session as well. But to introduce Dr. Ganpati Bantwal, he's the current president of the Endocrine Society of India. He's a reputed and experienced endocrinologist practicing in Bangalore. He's professor and head of the Department of Endocrinology at St. John's Medical College. So he's Professor Bantwal. Dr. Bantwal completed his MBBS from Mysore, MD also from MD in internal medicine from the same institute, and went on to do his DM from the prestigious PGI Chandigarh. Dr. Bantwal is a principal investigator in more than 50 clinical trials, and is a well-renowned endocrinologist with multiple peer-reviewed and indexed publications, both national and international journals. We're also proud to be associated with Dr. Atul Kalan. He has joined us now. Dr. Kalan is for me a mentor. In fact, I very well remember, I actually wrote to him regarding a letter of recommendation for the neuroendocrine organization. And just, really did me a good by writing an excellent recommendation so that I could join that society. He's a consultant endocrinologist working at and a professor at the University of South Wales. He's a director of the USW endocrine program. More importantly, he's a marathon runner and is author of several books on SC endocrinology. One you can see on the left, the best of 5 MCQs for the endocrinology and diabetes. So, if you ever want to give an SCE, this is the book you need to read. He's strongly rooted to India. He continues to love everything which Indians love, like cricket. He has done his MBBS from MEMC from Delhi, and he's done his MD from Safdarjung Hospital, New Delhi. And he's also done his MD in neuroendocrine tumors. He's an expert in neuroendocrine tumors from Cardiff University. So excellent human being and excellent teacher of endocrinology, Professor Kalan. And we are, about to be joined by Dr. Ahmed. He's both an endocrinologist as well as a technology consultant. So he's a consultant endocrinologist as well as a consultant in technology. Again, we are very creative people today. So he has, as you can see, made an app which is very famous, which I personally use it. It's endocrinology and endocrine emergency app, and I still remember using it during my endocrinology residency. I met him a few years back in Denmark. He's an excellent, endocrinologist. He's a specialist in endocrine and diabetes. He works with the Ministry of Kuwait. He's done his training from the University of Toronto, both his internal medicine and endocrinology training from there. But he's also done his Masters of Science in Computer Science from Georgia Institute of Technology. And we are proud to have him in the endocrine community. So we're going to start today by talk on exogenous Cushings by Dr. Saurabh Arora. And sir, if you're there, your floor is all yours.
A very good evening to all. Thank you, Dr. Om, for your kind introduction. First of all, I would like to thank Dr. Ganpati, Dr. Sanjay, and Dr. Rakesh Sai, sir, to give me this opportunity to speak on this topic, which is very relevant to the current scenario of COVID-19 pandemic. Actually, exogenous Cushing syndrome, it's a unique condition in which the patient on one side is having Cushingoid phenotype, but at the same time, adrenal endocrine system is working, it's hypofunctioning. The patient has hypoadrenal status. So these two are important issues which needs to be addressed in the management of patients with Cushing syndrome, exogenous Cushing syndrome. So the first therapeutic use of glucocorticoid, it was done in 1948, and it was used in a patient who had diagnosis of severe rheumatoid arthritis. And at that time, it was found that glucocorticoids use is associated with potential adverse effects. And as we know, glucocorticoid therapy, it's a frequent situation, and more than 1% of the population consumes glucocorticoid. And adrenal insufficiency after glucocorticoid treatment is a reality. There have been very few studies with biological systematic screening to establish the frequency and duration of the glucocorticoid therapy, which is required to cause adrenal insufficiency. And the clinical impact and risk of acute crisis is not really investigated. So here in this slide, we can see that prevalence of ever use of oral glucocorticoids in both men and women, it increases, the prevalence increases with increasing age. And with 90 years of age, the prevalence of glucocorticoid use, ever use of glucocorticoid reaches up to 6.5% in women. So as we know that glucocorticoid has immunosuppressive effects, anti-inflammatory effects, anti-allergic effects, for which these are the beneficial effects for which we use. These are the desired therapeutic effects of the glucocorticoids. But at the same time, glucocorticoid has some deleterious effects on the metabolism, which leads on to the increased risk of cardiovascular events, cataract, glaucoma, skin thinning, that I'll be discussing in my further slides. So the use of glucocorticoid is associated with various deleterious effects on metabolism, cardiovascular system, catabolism, and infection, such as it results in increased risk of hyperglycemia, dyslipidemia, thrombophilia, hypertension, increased risk of heart failure and ischemic events. In fact, the risk of osteoporosis is increased, myopathy, tuberculosis, and the risk of fungal infections. In patients with exogenous glucocorticoid use, the risk of fungal infection is even more as compared to patients with endogenous Cushing syndrome. So here in this slide, this was study published in BMJ 2012. And in this, we can see that patients who had not taken glucocorticoids versus those who had been prescribed with glucocorticoids but did not have typical phenotype of Cushing syndrome. And the third group of the patient had typical features of Cushing syndrome, iatrogenic Cushing syndrome. So the mortality was highest in those patients who were prescribed glucocorticoids and had typical phenotype of Cushing syndrome. And so coming on to the most common indications for the use of glucocorticoids in day-to-day scenario are autoimmune disease and inflammatory disorders. And most of the times, the glucocorticoids are used in higher dosages over a prolonged period of time. So synthetic glucocorticoids they are more potent. Most of the glucocorticoids, they are most potent and have more affinity for the glucocorticoid receptors as compared to the cortisol. So these patients have more striking clinical features than those patients of spontaneous Cushing syndrome. So how can we differentiate patients between exogenous and endogenous Cushing syndrome? So it's very important to differentiate between the two conditions so as to avoid unnecessarily diagnostic investigations and further workup for endogenous Cushing syndrome. So in those patients who have exogenous Cushing syndrome, features of protein catabolism are more prevalent and are more intense. Because of high potency glucocorticoids are used, and glaucoma, posterior subcapsular cataract, avascular necrosis, pancreatitis, osteoporosis, benign intracranial hypertension, all are more common in patients with exogenous Cushing syndrome as compared to endogenous Cushing syndrome. Lenigo hair are more commonly seen in patients with exogenous Cushing syndrome, and spinal epidural lipomatosis is predominantly seen in patients with exogenous Cushing syndrome. Whereas coming to endogenous Cushing syndrome, hypertension is a more common feature of endogenous Cushing syndrome as compared to exogenous Cushing, because most of the glucocorticoids, synthetic glucocorticoids, do not have significant mineralocorticoid activity. So hypertension is more common with endogenous, hypokalemia is more common with endogenous Cushing for the same reason, and androgen excess and hyperpigmentation are more common in ACTH-dependent endogenous Cushing syndrome. So hirsutism is a common feature of endogenous Cushing syndrome, but if hypertrichosis is present, that points towards the exogenous cause of the Cushing syndrome. So how to diagnose Cushing syndrome? 8-hour cortisol less than 100 nanomole per liter is diagnostic of exogenous Cushing syndrome. ACTH is not generally used for the diagnosis of Cushing syndrome. It can be low normal, and glucocorticoid screen, urinary or serum glucocorticoid screen, can also be used to establish the diagnosis of exogenous Cushing syndrome whenever the diagnosis is in doubt. We have few cases reported, and the patient had at the same time both exogenous and endogenous Cushing syndrome, and the mystery was resolved with the glucocorticoid screen at that time. So there are few exceptions to serum cortisol less than 100 nanomole. We have few exceptions if the patient is on hydrocortisone, because hydrocortisone cross-reacts with the assays. So cortisol can be falsely high in these patients. If the patient is on ACTH treatment, another condition, when with prednisolone, the cross-reactivity is not that common, but some assays can have cross-reactivity with prednisolone also. This picture can also be present during the recovery phase of axis following glucocorticoid withdrawal, when the patient had persistent phenotype of Cushing syndrome, but the axis is recovering, the patient has normal cortisol levels. So this is cortisol immunoassay cross-reactivity with various assays. This is with Roche immunoassay. Cortisol has high immunoreactivity, prednisolone high, whereas fludrocortisone has low cross reactivity, and dexamethasone do not cross-react with the assays. 17-hydroxyprogesterone and 21-deoxycortisol has low cross-reactivity, except in patients with 21-hydroxylase deficiency, where the levels are increased, and these precursor molecules can cross-react with the assays to cause high cortisol values. So there was a study done to look for the cross-reactivity of inhaled corticosteroids with the Roche cortisol immunoassay, and it was found that the inhaled corticosteroids, including betamethasone, fluticasone, and beclamethasone in the Roche cortisol immunoassay, do not significantly cross-react with the cortisol if given in therapeutic doses. So this is a corticosteroid equivalency table. As we know, 4 mg of prednisolone, 5 mg of prednisolone is equal to 20 mg of hydrocortisone and 0.75 milligram of dexamethasone. Whereas mineralocorticoid activity, methylprednisolone and dexamethasone do not have mineralocorticoid activity, and prednisolone has a lower mineralocorticoid activity as compared to hydrocortisone. So the factors implicated in the development of Cushing syndrome. So it depends by which route steroids are given, what dose of steroids are given, and for how long the steroids are taken. But it's very important to remember every mode of exogenous glucocorticoid delivery has been implicated in the development of Cushing syndrome, whether it is inhalational, intranasal, intralesional, or topical. Every mode has been implicated in the development of Cushing syndrome. And there have been attempts, researchers have been making attempts to separate anti-inflammatory effects from the metabolic effects with synthetic corticosteroids, but this has not been successful till date. But further extensive research is going on in this area. And synthetic glucocorticoids do not have significant binding to cortisol binding globulin and bind instead to albumin or circulate as a free steroid. This is one factor which is responsible again for the development of exogenous Cushing syndrome. And synthetic glucocorticoid, as I have already mentioned, has a much higher affinity for the glucocorticoid receptor than cortisol itself. And definitely the development of exogenous Cushing is related to dose and duration of the treatment. But there is data to suggest that even low potency agents with short half-lives like hydrocortisone and cortisone can cause Cushingoid effects if given in adequate amounts with frequent delivery. So predicting the dose and the time course at which a given glucocorticoid will cause Cushingoid syndrome is complicated by many factors, and it is almost impossible to predict that which patient will develop Cushing syndrome with what dose of steroid. This is because of different potencies of various glucocorticoids used, and we have different formulations and modes of delivery. But the most important factor is that each and every individual has different level of sensitivity to the glucocorticoid. So it's almost impossible to predict which patient will develop exogenous Cushing or not. Some manifestations of glucocorticoid excess occur relatively quickly, such as psychiatric manifestations like insomnia, increased appetite, can occur within hours of glucocorticoid administration, whereas typical Cushingoid phenotype takes weeks to months to develop. And this same is true for the development of osteoporosis. So there is tremendous variability between individual with regard to dose. Generally, the supraphysiologic doses are usually required before patient manifests with significant Cushingoid effects. And there is data to suggest that patients who are on post-renal transplant patients who are on glucocorticoid therapy, these patients can develop Cushingoid appearance with chronic administration of as little as 5 milligram per day of prednisolone. So, iatrogenic Cushing syndrome due to topical glucocorticoid use. Low doses of over-the-counter topical glucocorticoids are commonly used commonly, and systemic absorption of steroids from the topical preparation does occur. And at a higher dose or with more potent preparations, if given for a prolonged period, both adrenal axis suppression and exogenous Cushing can be seen. And skin disease causing the breakdown of skin integrity may play an important role in the development of exogenous Cushing syndrome. This was a case of 8-month-old female infant who developed Cushing syndrome and adrenal insufficiency after diaper dermatitis treatment because the patient was misusing clobetasol without the doctor's prescription for a prolonged period of time. So earlier on, it was thought that inhaled glucocorticoid therapy is relatively risk-free. But now we have case reports to show that patients can develop Cushing syndrome with the use of inhaled glucocorticoids. And there is significant systemic absorption. Effects are dose-related. And the most potent of inhaled steroids currently available is fluticasone propionate. So there were a case series of 6 patients with pre-existing HIV lipodystrophy who developed Cushing syndrome after the use of inhaled fluticasone, and at the same time, the patient was taking low-dose ritonavir-based protease inhibitor antiretroviral therapy. So ritonavir inhibited the metabolism of steroids and resulting in the supraphysiological levels of fluticasone, which resulted in the development of Cushing syndrome. So alone inhaled corticosteroids might not lead on to the, if taken in appropriate dosages, might not lead on to development of Cushing syndrome. But if taken with other significant cytochrome P450 enzyme inhibitors, can result in the development of Cushing syndrome. This has been reported with ritonavir. This has been reported with itraconazole. And recently, one case has been reported with posaconazole also. A patient with common variable immunodeficiency who received 7 years of itraconazole with inhaled fluticasone did not develop exogenous Cushing syndrome. But as soon as the patient was switched to posaconazole, the patient developed Cushing syndrome. So this is the first case of iatrogenic Cushing syndrome in the context of long-term administration of inhaled steroids and posaconazole therapy. So in these time, current COVID-19 pandemic, so we are giving steroids to the patients. Even some patients are on high-dose steroids. And at the same time, the patients are developing fungal infections, and mucormycosis is common nowadays. We are seeing a good number of patients coming up with mucormycosis, and for the prophylaxis of mucormycosis and for the maintenance treatment of mucormycosis, posaconazole is commonly used. So we have to be really vigilant in these group of patients. Preferably, we should try to use the low dosage steroids and try to stop these steroids as soon as possible in these group of patients. So even exogenous Cushing has been reported with nasal glucocorticoids also, most commonly seen in children, but has also been reported in adults. And intranasal betamethasone has been the most commonly implicated steroid. And there was a case of 28-year-old woman who developed Cushing syndrome while using betamethasone nasal drop over a 2-year period. Patient had been taking doses far beyond those prescribed by her physician. So prolonged courses of local steroids can lead on to the development of exogenous Cushing syndrome. And there have been case reports of exogenous Cushing syndrome due to intra-articular steroids, with intralesional steroids, example in keloids, with paraspinal depot injections, with local epidural steroid injections. There have been development of spinal epidural lipomatosis, and there have been 2-3 case reports of development of Cushing syndrome with serial occipital nerve blocks containing triamcinolone. So now coming on to the withdrawal from steroid therapy, it's a very important step because sudden withdrawal in patients who are on glucocorticoids for a long period of time can precipitate adrenal crisis, and it can be life-threatening at times. So possibility of suppression of high HPA axis and resulting secondary adrenal insufficiency should be considered in these patients. Another issue which affects withdrawal from steroid therapy is the possibility of worsening of underlying disease for which steroid therapy was initiated. It has to be taken into account before withdrawing steroid therapy, and steroid withdrawal syndrome that I'll be discussing in my further slides. And it has been seen that some level of suppression occurs even at physiological doses, but that does not appear to be clinically significant. So why does this suppression occur? It's not clear. But the postulated theory is that because if we are giving exogenous steroids even at physiological doses, we cannot mimic the circadian rhythm, which is present, circadian rhythm of cortisol, which is normally present in the body. So this is a continuous exposure which occurs, and probably this results in the suppression of the axis, but it is physiology, it's not relevant clinically. So exact doses and duration of treatment required for significant HPA axis vary between individual to individual, as individual susceptibility is different, and the sensitivity of every individual to the glucocorticoid is different. So single measurement of plasma cortisol does not permit a reliable appraisal of pituitary adrenal function. So what we can do for assessing HPA axis, we can do the dynamic testings are available. So here in this slide, we can see that cortisol exerts a negative feedback on pituitary and hypothalamus while decreasing CRH and ACTH. So when we give exogenous glucocorticoids, generally it's given in many a times it's given in supraphysiological doses. So it results in the suppression of CRH and ACTH. And here we can see in this diagram, above is the normal adrenal gland, and the second picture is of the atrophic adrenal gland, which is secondary to the use of exogenous glucocorticoids. There was a paper in NAGM which evaluated the role of CRH as a test to assess the HPA axis. In this study, the researchers found that pituitary adrenal function in patients treated with synthetic glucocorticoids cannot be reliably estimated from the dose of glucocorticoid, duration of therapy, or the basal plasma cortisol level. And in this study, they showed that testing with CRH is nearly as useful as insulin hypoglycemia testing in the assessment of pituitary adrenal function. But the issue is with the availability of CRH, and it's quite expensive. There was a meta-analysis in which it was seen that for risk of biological adrenal insufficiency after short-term glucocorticoid therapy ranges from 46 to 100% 24 hours after glucocorticoid cessation. So in this study, we can see that as the dose increases, prednisolone equivalent reached to 45 milligram per day. The adrenal insufficiency was virtually present in almost all patients. So there was one study which was published in a European Journal of Endocrinology. In this study, the researchers tried to correlate the clinical score, hypocortisolism clinical score, with the HPA axis finding on the dynamic testing. And what they found that the clinical score did not predict differentiation between the patients who had normal adrenal function versus those who had insufficient adrenal function. So there was no difference in the clinical score between these two groups. So it's almost impossible to predict clinically which patients will land up into the adrenal crisis or not. So for this, dynamic testing is required. So in another meta-analysis, it was shown that adrenal insufficiency after discontinuation of glucocorticoids occurs frequently, and there is no administration form, dosing, treatment duration, underlying disease for which adrenal insufficiency can be excluded with absolute certainty. So the percentage of adrenal insufficiency after discontinuation of glucocorticoid ranged from 75% after 10 weeks to 15% after 3 years. And the percentage of persisting adrenal insufficiency in patients followed for at least 1 year in this study ranged from 15% to 67%. So we can see that the risk of adrenal insufficiency the prevalence is quite high. So what are the factors that predict the development of adrenal insufficiency after the glucocorticoid treatment? It's the prednisolone equivalent dose of more than 20 milligram per day, but this does not hold true for all the patients. Definitely, the risk is more when the doses are used more than 20 milligram per day. And if the patient has taken glucocorticoids for more than 3 months of duration, the risk of adrenal insufficiency is again high in these patients. Evening intake, the chances of excess suppression is more. If the patient is having clinical phenotype of Cushing, the chances of adrenal insufficiency after glucocorticoid treatment are more. And if the patient is receiving co-treatment with cytochrome P3A4 inhibitors. So should all patients be treated after glucocorticoid treatment when the glucocorticoid treatment is withdrawn? So in adult patient, 2 options are suggested. But right now, currently, we do not have sufficient evidence being available to recommend one approach over the other. The first is systematic prescription of hydrocortisone and tapering as per withdrawal scheme. And another approach is patient education and prescription of hydrocortisone to be taken only in cases of stress. No approach has been shown to be superior to the other one. So when and how to treat? when the prednisolone dose is decreased to 5 milligram per day, that when we have come down to the physiological doses of prednisolone, then the patient can be shifted to hydrocortisone 20 milligram per day and can be slowly decreased to 10 milligram per day. And it has to be taken in 1 or 2 doses in the morning and midday. Progressive decreases of hydrocortisone doses according to the clinical status and hormonal evaluation every 3 to 6 months. That it has to be decreased from 20 milligram per day to 15 milligram to 12 milligram per day. But there is no one withdrawal protocol which is superior to the another protocol. So it depends. It's the area of experts' opinion. So there are no randomized control trial which has been conducted in this field. But the most important, out of all this, the most important thing is we have to educate the patient regarding the use of stress dose. Patient has to be educated to increase the dose in case of stress, which is very important. And patient should be asked to wear the bracelets or something in the wrist to make aware that the patient is having Addison's disease and for the education purpose. And the various tests we have for hypothalamic pituitary adrenal axis recovery. To say that one test is superior to another, it's not true. So it's a matter of controversy which of the available tests best predicts or best correlates with the actual ability of the patient to handle the stress. No doubt the gold standard is insulin tolerance test. But as we know, this is a quite cumbersome test, and the risk of hypoglycemia and risk of seizure remains with this test. Another test is post-syntropin stimulation test, either 1 microgram or 250 microgram. Both the doses can be used. 1 microgram is as good as 250 microgram dose. And another test is CRH stimulation test. Is simple and safe, but it's an expensive test and CRH is not widely available. So there is doubt, however, that either of these is sensitive or specific enough to screen for secondary adrenal insufficiency. And overnight metarapone test can also be used, but there is a risk of inducing adrenal insufficiency concerned with this test. So it is best avoided. Now, another entity is steroid withdrawal syndrome. So this entity is poorly understood. So the steroid withdrawal syndrome is characterized by lethargy, malaise, and anorexia. The patient also complains of myalgias, can also complain of headache, fever, and even accompanied by desquamation of skin. So these patients typically have normal hypothalamic pituitary adrenal axis. So it's rare and the exact etiology is not known. Many of these patients has become psychologically dependent upon the steroids. And these patients typically do not appear to be at increased risk of cardiovascular system collapse or other extreme effects of adrenal insufficiency. And choice whether to continue replacement doses of steroids must be decided between the physician and the patient. So there was one case, only a single case reported, where a patient, 19-year-old male, developed seizure after dexamethasone withdrawal, and patient had seizure on both occasions within 2 days of stopping dexamethasone. It's very rare and uncommon event. So no controlled clinical trials of methods for withdrawal from glucocorticoids. It's a field of expert opinion. So withdrawal plan, therefore, are to be based on the dual goals. One is we have to completely discontinue therapy in order to avoid adverse effects of long duration of corticosteroid therapy. And another is avoiding the potential consequences of adrenal insufficiency. So the hormonal assessment after the patient has reached the physiological doses and has been shifted to hydrocortisone, evening dose of the hydrocortisone. We should ask the patient to skip the evening dose of hydrocortisone, and then 8 a.m. cortisol has to be done. If the 8 a.m. cortisol is less than 130 nanomole, then we have to continue with hydrocortisone and repeat the test every 3 to 6 months. If it's between 138 to 500 nanomole, then ACTH stimulation has to be done. If after ACTH stimulation, the value of cortisol is more than 500 nanomole, We have to stop hydrocortisone less than 500 nanomole. We have to continue with hydrocortisone and repeat the test every 3 months. If the patient is having 8 AM cortisol more than 500 nanomole, we can stop hydrocortisone safely. So most patients with adrenal insufficiency at first hormonal investigation will recover within 6 to 12 months. The exceptions to this are when the patient receives exogenous glucocorticoid treatment started again for the underlying disease because of the flare of the disease, and there is poor patient-physician connection leading to hydrocortisone overdose, and there is glucocorticoid withdrawal syndrome leading to high dose of self-administered hydrocortisone, that is more than 35 to 40 milligram of hydrocortisone in some patients. And what are the general measures that need to be taken to decrease the prevalence of exogenous Cushing development of exogenous Cushing syndrome? The most important is dose and duration of glucocorticoid therapy should be kept as low as possible. Pulse glucocorticoid therapy should be used only when absolutely indicated. We saw in the first wave of COVID-19 in India, there was a time when pulse glucocorticoid therapy came into vogue. At that time, we had observed in our institute also, it was observed over pan-India, that with the use of pulse glucocorticoid therapy, the risk of secondary fungal infection like sepsis with Aspergillus candida and even the secondary bacterial sepsis increased. So pulse glucocorticoid therapy should be used only when it is absolutely indicated. Glucocorticoid sparing agents should be used whenever possible. Short-acting glucocorticoids are preferred for replacement therapy in adrenal insufficiency over the longer-acting glucocorticoids, and use of highly potent and long-acting glucocorticoids, for example, dexamethasone, should be restricted to the acute settings only. To some specific measures, as we know that the exogenous glucocorticoid use is associated with rapid decline in bone mineral density that begins within the first 3 months of glucocorticoid use, peaks at 6 months, followed by a slower steady loss with continued use of glucocorticoids. And there is increased risk of both vertebral and non-vertebral fractures. Vertebral fractures associated with glucocorticoid therapy are often asymptomatic, so lateral spine X-rays can be done to look for asymptomatic vertebral fractures, especially in elderly patients. BMD should be done at baseline and then annually along with the height measurement in these patients, and BMD alone may not be able to predict the risk of fracture. So we have to stratify the patients using FRAC score. We have to stratify the patients into low risk, medium risk, and high risk. And according to the risk category, in case of low risk and medium risk, bisphosphonates are recommended if the glucocorticoid use is expected to last or has already lasted at least 3 months and the dose used is 7.5 or more than 7.5 milligram per day of prednisolone. And in high risk category, the treatment with bisphosphonate is recommended regardless of the dose and duration of glucocorticoid use. And for premenopausal women, the treatment with bisphosphonate is recommended only in case of fragility, fracture. And bisphosphonates improve bone mineral density and decrease the risk of vertebral fractures. Teriparatide can also be used. It is more effective in the management of glucocorticoid-induced osteoporosis with increases in bone mineral density compared to alendronate. Denosumab is not approved by FDA for use in glucocorticoid-induced osteoporosis. Calcium intake has to be kept in between 1200 to 1500 milligram per day, and vitamin D supplementation of around 800 to 1000 units per day is recommended. Weight-bearing activity, smoking cessation, avoidance of excessive alcohol needs to be followed. And another complication is osteonecrosis. Glucocorticoid therapy's most common cause of non-traumatic cause of osteonecrosis can occur even in the absence of glucocorticoid-induced osteoporosis, and the risk appears to be increased with high dosages and prolonged treatment of glucocorticoid. And glucocorticoid-induced avascular necrosis tends to affect multiple joints, though most commonly hip and knee joints are affected. There is no consensus to recommend universal screening for asymptomatic AVN in long-term user of glucocorticoids, but it's a high index of suspicion which is required to diagnose AVN at an earlier stage. So conservative management includes bed rest and reduction of weight bearing, and in the later stages, Generally, surgical management is required in majority of cases. At present, there is not enough evidence to support the routine use of bisphosphonates in patients with avascular glucocorticoid-induced avascular necrosis. So in children, growth failure is a particular problem with the use of exogenous glucocorticoid therapy. And risk of growth failure depends upon dose, duration, and potency of the steroids used. And potency of dexamethasone and betamethasone in suppressing growth has been shown to be nearly 18 times higher than that of prednisolone. So it is preferable to use lower potency agents in children whenever possible. Deflazacort in some studies and alternative day glucocorticoid therapy have shown less suppressive effects on growth, but this has been shown in few case studies, and more studies are needed. And routine use of growth hormone in patients with glucocorticoid-induced growth suppression cannot be recommended due to lack of adequate evidence. Now coming on to the ophthalmological adverse effects. And these ocular side effects are some of the most neglected side effects of the glucocorticoid therapies. And corticosteroid use is associated with the development of posterior subcapsular cataract. And this cataract is different from another other type of cataract because it affects vision more significantly than other types of cataract and usually requires earlier surgical intervention. So it develops only when high doses of glucocorticoids are given for a longer duration of time. And it is high doses are also associated with painless increase in intraocular pressure. It can also cause permanent optic nerve atrophy and visual field defects if left untreated and glucocorticoids are not withdrawn. And glaucoma is more serious ocular complication of glucocorticoid therapy as compared to the cataract. For these complications, annual ophthalmological assessment is required in patients who is receiving exogenous glucocorticoid therapy. So this was about the general and specific measures that we can take to avoid the unwanted effects of the glucocorticoid therapy. So to summarize, I would say that dose and duration of glucocorticoid should be kept as low as possible to avoid the deleterious effects of the exogenous glucocorticoids. Short-acting preparation of glucocorticoids like hydrocortisone has to be preferred for replacement therapy in patients with adrenal insufficiency as compared to the long-acting preparations. Adrenal insufficiency after glucocorticoid treatment is a reality and do occur. So we have to assess the HPA axis every 3 to 6 months with morning cortisol plus minus ECTH stimulation test depending upon the cortisol levels. With appropriate management, most of the patients will recover. Thank you. With this, I hand over to the organizers.
Thank you, Dr. Saurabh. It was an excellent talk. I think you covered exogenous Cushing's in a three-dimensional way, right from the, how to diagnose it, how to treat it, how to mitigate the issues, and deal with long-term complications. So I think it's an excellent presentation. We'll be taking questions after our panel discussion. We'll be taking some questions during the panel discussion as well. So those who are listening to this and those who have joined us, you can put your questions in the chat box. Those who have joined us on YouTube can also put the questions in the comments. So they will be relayed to us and to our esteemed panelists. Thank you, Dr. Saurabh. Can you just unshare your screen so that I can?
Yes, sir.
Thank you. Okay, so now we are going to the panel discussion on this topic. And those who are joining us for the first time in this series will be, we are joined by some expert panelists who are international endocrinologists. And we are also joined by our Endocrine Society of India President, Dr. Ganpati Banswal, sir. Dr. Saurabh Arora will be around. He'll be also answering some questions from us as well. So we have made a set of questions. Now, these questions are not ironclad. They are just basically points of discussion. So, we'll allow the flow to go, and it's an open session for learning. Okay, so just to reintroduce our panel, Dr. Saurabh Arora, he's DM endocrinology from BHU. He's assistant professor of endocrinology from Ludhiana, and he just gave an excellent presentation on the topic. Dr. Bantwal sir, he's the current president of Endocrine Society of India, a professor and head of endocrinology at St. John's Medical College. Dr. Atul Kalan, consultant endocrinologist from University of South Wales, deeply rooted to India. He has done his MBBS and MD from Delhi, and he's the director of USW endocrine program. And he's also the author of multiple books on endocrinology, and he's a great teacher. So that's his introduction. Dr. Ahmed, he's been kind enough to join us from Kuwait. I think it's the first time we have an endocrinologist from Kuwait in an Indian program. So I think that's the first. He's an excellent speaker. I met him personally. We had a series of debates in Denmark, I remember. And he is also a technologist. So he's made many apps, and he has keen interest in using technology for endocrinology. So welcome, Dr. Ahmed. So these are the panelists, and we'll be addressing the question to one of the panelists. Again, like I said, this is just basically a starting point for discussion, and we allow the flow to go as we go. Right? So, Dr. Kalan sir, now let's start with the terminology itself. Are you happy? Because a lot of the times in endocrinology, especially, we often look back and say that, boss, who called this type 1? They should have called it an autoimmune diabetes, or who called this, Cushing syndrome? It should have been called something to do with, pituitary or adrenal, right? So, what do you say about the terminology? Would you like to call this as exogenous Cushings? Would you like to call this as an iatrogenic Cushings, or would you like to call it as an glucocorticoid excess syndrome or exogenous glucocorticoid excess syndrome? What's your view on terminology?
Thanks, Som. It's a fantastic opportunity for me to interact with such an esteemed audience. If you go by Shakespeare, what's in a name? What you call as rose would have smelt as sweet if called by any other name. As long as the term is able to convey what you want to say, it's a perfect use of that particular word. So exogenous from endogenous perspective is fine. But in our practice, I commonly use iatrogenic Cushing because it clearly points out that there is a medication or some factor which is leading to it. So in my opinion, it's a very personal, humble opinion that these can be used as you feel comfortable. But the key thing which needs to go to the general public or our primary physician colleague is that be aware of this entity, because iatrogenic Cushing or exogenous Cushings is probably 100 times even more common as compared to endogenous. In endocrine practice, I've been searching for diagnosis of Cushing in my type 2 diabetes population, my younger individuals with growth retardation, but it's very easy for me or most of us to find iatrogenic Cushing or exogenous Cushing. So as long as the message is given, I think it doesn't make any difference.
Yeah. So the point being that the message should be conveyed, and more importantly, the primary care physicians and the patients themselves should be aware of these very important and very common endocrine condition. Coming to Dr. Ahmed, apart from overt systemic glucocorticoid use, and Dr. Saurabh talked about this a bit. He talked in a very polite way. I think in current era, there's a lot of debate on this. What other medicinal or alternative products that you encountered in your country that potentially lead to exogenous Cushings? Sometimes it's occult. We had one paper in JCEM which talked about Cushings from a plant. And there are certain plant products which have glucocorticoid-like properties. So, from your country, how when have you experienced such occult Cushing's syndrome because of some alternative medication use or so on?
Yes, absolutely. Thank you for the invitation and for the talk, and it's a pleasure being here with you all. I think I've had two interesting cases, multiple interesting cases, but like two scenarios what I've seen. One of them is patients who are taking honey that is supposed to be medicinal honey, or they were told that this is honey that will improve your asthma, that sort of thing, that it has special properties. But we know that this honey, what they do is they add steroids to it. So they put steroids in the honey, they put usually dexamethasone, they mix it with the honey, and then tell their patients, I'll tell people that, if you take this honey, you can get rid of steroids. You don't need to take any steroids anymore. You can get rid of your steroid inhaler to make you feel better. But clearly, the problem is that they're getting a big dose of dexamethasone. There is no dose control. You don't know how much they're getting. And I've seen patients who've had this. Another one, so in addition to honey, some patients are actually given the pills themselves, but they're reassured and told that it is not steroids. So I had a patient once come in to clinic with a blood test result, and she said that she wanted to gain weight. She was getting married, and she was worried that she was too thin. So she found someone online who said that they would give them a medication that would help them gain weight. She was worried that it's going to be steroids. So she asked this vendor, she said, is it steroids? Does it contain steroids? And the vendor confirmed and insisted that it does not contain any steroids. So she took it, she started gaining weight, but she started suspecting that this is actually dexamethasone or steroids, basically. So what she did is she went to the lab and did a cortisol level. And so she came to me and said, I've gained weight, and I took this pill, and I told her, you're definitely taking glucocorticoids. And then she takes the blood test result out and shows it to me, and she says, no, I have proof that I'm not taking cortisone, because look, my cortisol level is very low in the blood test. And I explained to her that, that this is just because your own endogenous production of cortisol has gone down because of the, of course, suppression from dexamethasone. So what I told her is, what you just did is called the dexamethasone suppression test, and now we can confirm you don't have Cushing's, but you from an endogenous cause, but you definitely have Cushing's from taking the steroids. And so those would be the two things. So it's either honey that's been with steroids added to it, or some people who take those pills, dexamethasone pills, but are told that it's not steroids falsely by those who sell it to them.
Yes. So Dr. Bantwal sir, now putting you in the spot, not as the head of Endocrine Society of India, but as a endocrinologist who's been practicing since many years, what are these unusual cases of exogenous Cushings that you're seeing, where you were not aware about what the product was, and like that Dr. Ahmed said, maybe honey, maybe some powder, some story you'd like to share, at least doctors are practicing can be aware of, where does the steroid come from?
Important thing is the skin creams, actually. So though we say they don't produce, but then it can produce. So there was one person who denied everything, and finally we came to know that it was because of the creams which he was applying. And then, as you told, like this only, the jadi booties, no? So we have people coming from the rural sites. They also come sometimes with asthenia, all these things. So they are the ones, actually, if you check their cortisol levels, it will be low, indirectly telling that they have been on these medications. So these are the two main groups. Others will usually have an evidence of that he would have received an injection in the, in the joints. He would have taken a long-acting preparation. So we have that. But then these are some scenarios, especially the creams, I would say, and the persons coming from rural areas where we normally find do a cortisol level, they are invariably suppressed in these type of patients.
Yeah. So again, to the audience, to reiterate, a patient who looks Cushingoid, but the baseline cortisol is low, as Dr. Saurabh Arora, discussed very well. That's the patient where you should suspect strongly that there's an exogenous steroid administration. Dr. Kalan sir, you have experience both from India as well as the UK. Any stories you'd like to share about exogenous Cushings so that people are aware what they are?
The thing which I can say is topical ointments remain quite common agents which are ignored, especially if the involvement of huge amount of skin, huge volume of skin is there. The second thing is, still despite everything, people get mixed up with the doses of steroid also. So I do remember an individual who was on a higher dose of prednisolone, and the primary care colleague didn't change it. And the weight gain, multiple other things, worsening of glycemic control, all were related to it. So in fact, I think your question is extremely relevant at the moment in the current COVID crisis, when steroid use has become so rampant. If there is one medication I don't want people to have over the counter, it's the steroid. And there was a very good point raised by Ahmed about the honey. I think it was a honey trap, Ahmed. They were mixing prednisolone with the honey and honey trapping the patient.
Okay. So,
Absolutely, yes.
okay, moving to the next question for Dr. Ganpati sir. I mean, we talked about this, I think, but something you'd like to add, any alternative medications, which can lead to Cushing's?
I think I've answered that question.
Sure.
Yeah,
I think we'll move on, sir.
Yeah, I think that's right. It's the same, basically. Yeah.
Sure. Dr. Saurabh, so we talked about some overt signs. You did talk about, I think you discussed this in your talk as well. But would you like to reiterate some subtle signs of exogenous Cushing's intake, which may not be visible very, very obviously, but astute clinician would really pick that up and possibly consider looking for exogenous steroid exposure?
Yes, sir. Possible stria, obesity, increase in weight gain, these are overt signs. But there are some subtle signs which we can pick on the clinical examination. And one important sign is thinning of skin. Thinning of skin. Thinning of skin can be measured while using caliper. And if it is less than 2 millimeter, it is called thin skin. Thin skin in the presence of excessive weight gain, there is quite high likelihood of having Cushing syndrome. So patients with the background history of steroid use and thinning of skin, it's one indicator. And especially if it is associated with ecchymosis, which are non-traumatic, then the likelihood of Cushing syndrome, again, it arises. And again, in the current era, patients coming with weight gain, impaired glucose tolerance, and repeated fungal infections, these are other subtle markers which can point towards the exogenous glucocorticoid use. Like certain features I discussed, it's more common with exogenous as compared to endogenous Cushing syndrome. It was like the patient developing cataract, glaucoma, pancreatitis, and even if the patient comes to with recent onset of impaired glucose tolerance along with proximal muscle weakness, it's a constellation of symptoms and signs which we have to look. And the patient also reports mood disturbances and psychiatric manifestations. Possibly we should consider exogenous Cushing in these group of patients, even if the typical manifestation of exogenous Cushing are absent. And in children, especially in pediatric patients age group, definitely auxological parameters are very important, and serial photographs, if we can see, that's quite helpful in the diagnosing subtle features or subtle progression of facial appearances.
Excellent. Just to tell you, Dr. N.K. Agrawal has said, good presentation, Dr. Saurabh. So thank you for that. Okay, Dr. Karan sir, I think again this has been discussed. Steroid withdrawal syndrome. This Dr. Saurabh talked about quite a bit. So in your opinion, in your experience, how have you seen psychogenic aspects of steroid withdrawal, and how do you deal with that? How do you because there are a lot of patients. It's really difficult to get them off the steroid. In that sense. From a physiological point, yes, but from a psychological point, it becomes really difficult. So how do you deal with steroid withdrawal?
Thanks, Om. I'm a very simple clinician and I follow only few dictums in life. My checklist for steroids, one obviously is the dose. The normal physiological cortisol production will be around 6 to 8 milligram per meter square. So if we deem an average Indian to be around 1.6 to 1.7 meters, not many will need in physiological states more than 12 milligram. Now, once you start to reduce the dose, and Saurabh had done an excellent presentation on it, how to do it and the approach to it. Once you're on the lowest possible dose of that steroid and you try to stop it, the mood disturbances, the fatigue, the malaise, these may be indicators that it's a tertiary suppression of the hypothalamic pituitary cortisol excess. So in a sense, the key thing for us to do is to establish one, that once we are withdrawing from that point of that amount of dose, we recheck the ACTH cortisol excess, and we do Short-Snectin test in here. And as Saurabh was mentioning about the cutoff values and all, the key thing becomes is, are you able to get over these kind of side effects? How many of these you are attributing to the psychological part of it or the real suppression of the ACTH cortisol excess? So my only suggestion will be to play it safe, test the excess again. If it's normal, then it becomes much easier for you to withdraw it. And but to distinguish between the psychological impact versus the real suppression, it's a bit thin line of demarcation. So be safe and retest biochemically, dynamically.
Excellent. So the take home here being that, don't assume that it's just a psychological impact. There could be a real physiological, reason behind it. And I think, it would be a great idea to retest the axis before you consider this just as a patient quirk rather than being a true, telltale sign of adrenal insufficiency. Great. So thank you, sir. So Dr. Ahmed. So again, we at the end of the day, like Dr. Saurabh said, that this disease is bifold. On one hand, you have the features of exogenous Cushing, you have the features of glucocorticoid excess, but again, at the same time, it's been withdrawn, and some of the patients come to you in a state of adrenal insufficiency. So how long does the tertiary adrenal insufficiency remain after steroid withdrawal in cases where the hypothalamic pituitary axis has been affected? So for example, let's say there's a patient on dexamethasone for a long time, inadvertently, and then, comes to you in a situation of tertiary adrenal insufficiency. And like Dr. Kalan said, you test the axis, you find that it's involved, the cortisol is low, like the patient you talked about. So how long would it take for the axis to completely recover? In your experience?
That's a great question. So there are two components here. The way I think about it is we have two issues here. The first one is the day-to-day, the normal physiological day-to-day kind of requirement, and that usually, in my experience, takes maybe sometimes a month or two or even 3 months sometimes. But by then you can successfully usually stop the steroids by then. So usually what I do is I go to a short-acting steroid like hydrocortisone, Cortef, in the morning once daily at first. And tell them, like you might feel a little bit tired towards the end of the day, but just wait a little bit. Give them somewhat sub-physiological dosing to stimulate the recovery of the axis. So that's what I usually do. And then eventually, in 2 or 3 months, maybe, partly they get used to the new state, and part of it is their adrenal axis improves, and then we can stop it. So that may be within 2 or 3 months. But I think what's important to remember is that even though the axis may recover to a degree where you can sustain normal physiological days, if you go on stress, then you might end up needing stress dosing. That your axis may not be robust enough to be able to deal with a stressful day. So I tell them to keep the steroids with them and continue to use the bracelet in case they, God forbid, they get in a car accident or something. Then they will need steroids. If they are very sick in the hospital, they will need steroids. Even if they have a more mild illness at home, I tell them to take stress dosing of steroids. So I tell them to take double the dose they were on at the end as their stress dosing for 2 or 3 days, and then stop it. Of course, you don't want to encourage them to keep taking it a lot. Every time they wake up in the morning, they feel a little bit unwell, they might start taking it. Then you will never be able to get the access to recover. But at the same time, I think it is sometimes unsafe to tell them to not take anything, even when they are not feeling well. So it's a balance between the two. For that, I think it can be up to a year. And I usually tell my patients to continue taking stress dosing of steroids if they get sick for up to a year. If they continue for a whole year and they don't need a lot of stress doses and they're not continuing while they're taking steroids, then usually I would say that it's safe now and we can stop it. You can do an ACTH stimulation test to confirm that they can have a very robust response. But of course, that could just be, like it could be an indication of recovery of the adrenal itself, but maybe there is still, suppression at the level of the pituitary. But usually, if there was suppression at that level after this long period of time, you would see adrenal effects too. So usually an ACTH stimulation test is good enough for me. So it depends. If it's a patient who's never had an adrenal crisis, never shown any severe symptoms of adrenal insufficiency, I might just tell them to take stress dosing for up to 6 months to a year, and then if nothing happened, then that's it. They can stop. I don't do any repeat testing or anything like that. But in some cases, I might be more cautious, and I might decide to do an ACTH stimulation test at the end of the year to make sure that they can get a very nice cortisol rise to like 500 or 600, and then I'm reassured and tell them that they don't need stress dosing of steroids anymore.
Excellent. So, to summarize, basically, in the beginning, you might have to give them steroids per se, but the excess may not completely heal for quite some time, almost like a year, you said. And some of these patients, if they do develop a physiological stress situation or any other perioperative situation or something like that, in that cases, it would be wise to consider giving short stress doses to cover that period. Right. So great point. Moving to Dr. Ganpati sir, what glucocorticoid do you consider using in patients with tertiary adrenal insufficiency secondary to Cushing syndrome? Dr. Ahmed talked about how he gives them a milder glucocorticoid like hydrocortisone, and then allows it to kind of the excess to recover. So in your practice, what kind of glucocorticoid do you use in such patients with tertiary adrenal insufficiency?
In our practice also, we use the same hydrocortisone tablets itself, as Dr. Ahmed told, because you give them sometimes for recovery also. So because of its short-acting effects, you see that we are stimulating our own gland to recover from the suppression which is happening. Of course, if there are patients who are not able to get the hydrocortisone tablet, then we will continue to use prednisolone once a day. Say maybe I may begin with 5 mg, then I may reduce it to half. We do up to 1/4. And after that, of course, you can't break the tablets furthermore. And then we'll tell them, no, now you must actually buy hydrocortisone tablets, or at least try to procure it. And then 1/4, it's roughly equivalent to around 5 to 7.5 mg of hydrocortisone. That we divide it, then reduce the dose of hydrocortisone furthermore, make it once a day as Dr. Ahmed gave. And then we start monitoring his cortisol levels. The moment the cortisol starts getting detected, that is a sign that it's improving. So the moment you find 2-3 micrograms per deciliter in the morning, see, you don't have to give the afternoon dose. It's taken only in the morning, and that's enough. And the cortisol is detected indirectly means he's recovering from his axis. If you want to be doubly sure, you can do an ACTH stimulation test, and if you get it more than 20 micrograms per deciliter, indirectly says is recovered. There could be some who have a level less than 10. I mean, it's around up to 10 they'll have, but they don't cross 20. 10 levels. In them, we tell, okay, now you require only stress dosing, a little bit about 10, but not crossing 20 micrograms per deciliter. We tell them to take stress dosing itself. Because what has been found is you just require around 7 micrograms per deciliter, the blood levels, for fully saturating the glucocorticoid receptors. And people who are having just 2 to 3 micrograms, which is around 100 nanomoles per ml, those persons are just walking around, nothing happens. So even they may undergo a surgery and nothing happens to them. So if you don't involve a cavity, the surgery, it's said they could tolerate it. So that's the reason we find them, many of them 2 microgram, 3 microgram doing fairly well. But then they require stress doses for major things like what Ahmed said. So this is what we follow. So if they don't have hydrocortisone, go for prednisolone, come up to 1/4. And then we tell them, no, please try finding. Even when they are on prednisolone, I think there was a question where the half-life, say you have used half a tablet of prednisolone and the the cortisol starts getting detected now. It's an indirect indication that the patient is recovering.
Okay, great. So and so one question from the audience question, professorial level question kind of. What is the reason for the posterior subcapsular cataract that we see?
I think that Saurabh must answer.
Okay. Yeah. Thank you. So, Dr. Saurabh,
Yes.
little bit more about oral hydrocortisone. So, is oral hydrocortisone available? Again, a lot of audience may not be aware, and like this is a endocrine physician interconnect. So, is oral hydrocortisone available in India? And I think this has been discussed a little bit. What's the advantage overall of using oral hydrocortisone? Just you can reiterate that fact. And the third part of this question is, for a physician audience, do we need fludrocortisone also to be added to this system for tertiary adrenal insufficiency?
Yes, sir. To the first question, oral hydrocortisone is available in India. The answer is, as we have already discussed. I'll discuss the various types of steroids. First, I'll compare hydrocortisone with cortisone acetate, prednisolone, and dexamethasone. And I would like to use I would like to emphasize that it is better to use hydrocortisone in place of other steroids. First of all, if we compare with cortisone acetate, cortisone needs to be converted to cortisol by 11 beta HSD1 enzymes. So the pharmacokinetics are not very predictable if we use. And another, in patients with severe liver disease, in patients who are having cortisone reductase deficiency, or there is a condition in which we are using growth hormone, so we cannot predict the response. So the conversion is impaired. So hydrocortisone does not need conversion into the active metabolite. So it's an active form. And so that's why hydrocortisone is preferred over cortisone acetate. But if we compare hydrocortisone with dexamethasone, definitely hydrocortisone is preferred because dexamethasone has quite high, dexamethasone is a high potency steroids, and the suppressive action on the hypothalamic pituitary axis is much more as compared to the hydrocortisone. So in a patient in whom we are trying to withdraw the steroids and allowing the axis to recover, so there is no idea to use dexamethasone. So now we are left with the two options, hydrocortisone or prednisolone. So in adrenal insufficiency replacement doses, there has been a debate that prednisolone once a day compliance is better, so it can be used in place of hydrocortisone. But as far as withdrawal scheme is concerned, what I feel that hydrocortisone is a better option as compared to prednisolone because of the shorter duration of the half-life of this drug. It peaks very early and then the levels fall down after 4 to 5 hours in the blood. So this allows the axis to recover more as compared to the prednisolone, which has longer biological half-life for around a day. So this is preferable. But in some patients, while withdrawing steroids, if a patient experiences edema, so in those kind of patients, we can think of giving prednisolone because the salt retaining activity, mineralocorticoid activity of prednisolone is less as compared to the hydrocortisone. But otherwise, in majority of the times, hydrocortisone scores over prednisolone if we compare the withdrawal regimens, not the replacement regimen for primary adrenal insufficiency, because in this, our aim is to allow the axis to recover. And even fine doser adjustment, as Dr. Ganpati sir has already told, it's better with hydrocortisone as compared to the prednisolone. And to your third question, that whether we should use fludrocortisone in tertiary adrenal insufficiency, the answer is no. We should not use fludrocortisone in these group of patients because fludrocortisone generally ACTH, and CRH controls ACTH. ACTH controls cortisol production and the sex steroids production, but from the adrenals. But the mineralocorticoid axis, that is the sodium and potassium balance, this is mainly controlled by the renin-angiotensin axis, which remains unaffected in these group of patients. There might be some effect of ACTH, but it is not clinically significant to cause hypotension and adrenal crisis. So majority of the times, fludrocortisone is not needed.
So the message being that, and somebody asked in the chat box as well, I think we should have clarified this earlier, what exactly is tertiary adrenal insufficiency? So just to answer that, primary adrenal insufficiency is basically when you have the adrenal insufficiency because of adrenal gland. For example, the last discussion that was on Addison's disease or, tuberculous adrenalitis and so on. Secondary adrenal insufficiency is when you have a, problem at the level of the pituitary. For example, patient undergoes a pituitary surgery or so on. And tertiary adrenal insufficiency is when you have the problem at the level of the hypothalamus, suprapituitary, hypothalamic axis. And when you give steroids from outside, it not only suppresses the pituitary, but it also suppresses the CRH from the hypothalamus. So then, hence this disease is known as tertiary adrenal insufficiency. So just to clarify to the audience who asked this question. Okay, coming back to Dr. Kalan sir. Now, this is something which we've been working on as a research. It's still not published, so we'll dwell upon this. But there are several papers on use of DHEAS as a marker, not only for diagnosis of exogenous Cushing syndrome, but also as a tool for follow-up of patients to assess the recovery of the HPA axis. The good part about DHEAS is that the assay does not interfere with the the patient may be on glucocorticoids and, you can still undergo these tests because these, there's no cross-reactivity here. So have you used DHEAS in your protocol? Have you come across such papers? And if yes, how do you practically use it in your practice? Sorry, so you're not audible. I think this. Yeah.
So obviously, there is evidence from the observational studies which is emerging about the potential utilization of DHEAS for diagnosis of iatrogenic or exogenous Cushing. But till this is validated, a safe clinician like me will still rely on short Sneckton test to reassess the excess. So I'm aware of it, and I'll wait for your paper also, but if I can hint, I can sense something is up the sleeve on your side. But till it's properly validated, endorsed by the society, as a clinician, I feel a bit uncomfortable about using it. Maybe I'll start using it in addition and probably collect some more data. But my, our assessment for HPXs is quite simplistic kind of, and both Dr. Ahmed and Dr. Ganapati had, touched on it very nicely. Keep the patient on the lowest possible dose of hydrocortisone or prednisolone, whatever is preferred, and either 9-AIM cortisol or, if in doubt, do a short Sneckton test. But I think watch the space for DHEAS at the moment. I'll not jump into it at the moment.
Sure. So, sir, talking about the debate on hydrocortisone versus prednisolone, what's your take on that? Because I think it's hotly debated in the UK. Yeah. We had several pros and cons, and I think it's a very frequently debated topic there, as I understand. Yeah. So, what's your on which side of the debate are you?
So, the thing is,
allow you to be diplomatic.
For primary adrenal insufficiency, I go for hydrocortisone. I've used it. Okay. For longer duration, it's got mineralocorticoid activity. For secondary adrenal insufficiency, prednisolone, especially post-op hypopit patients, use the lowest dose. It was Prof. Karim Miran's group which had presented the data that they are using prednisolone as low as 3 to 4 milligram post-op. And I think that makes a physiological rationale also. So it's the cost of the therapy which has changed. Prednisolone is relatively inexpensive. Hydrocortisone, all of a sudden the prices escalated. And in NHS, we are very judicious about the resource utilization. So as the things stand, I'll for primary adrenal insufficiency still go for hydrocortisone, prednisolone for the secondary one.
Right, great point. Okay, so coming to Dr. Ahmed, again, this has been discussed a little bit, but what's your take on inhaled steroids and dermatological preparations, which can lead to tertiary adrenal insufficiency? And
yeah.
how have you experienced it? For example, especially, we've seen, let me phrase it in another way. We see a lot of COPD patients, right, on inhaled steroids for a longest period ever, or asthma patients. And let's say they're put up for perioperative situation, or let's say they develop, mucormycosis like they do in India these days now, post COVID. So, inhaled steroids, would you consider, before they are subjected to surgery, would you consider checking their HPA axis, or would you consider giving them perioperative stress doses of glucocorticoids? What's your take on that?
Yeah, honestly, if they don't, so, as you know, sometimes those patients will be also getting a lot of systemic steroids because they have the exacerbation. So if they're getting systemic steroids on like relatively frequently and very high doses of inhaled steroids, then I might consider it. But most of the time, I don't usually do any HPA axis assessment if they don't have clinical features of Cushing's disease. And I do check the skin thickness as part of my routine assessment of those patients. I haven't personally seen patients with HPA axis suppression due to non-systemic steroids. But like I always tell the students, and when I teach them that the problems would be either if it's dermatological, if it's a very large area, which we've discussed before and talked about before. So if it's a very large area of the skin that they're covering with steroid cream, then that can be a problem. Sometimes patients don't realize that they're overusing it, or maybe they confuse their creams and they have a steroid cream and they think it's just a moisturizer and they apply large areas over a long period of time, and then it can develop some Cushingite features, like theoretically. But I haven't seen anything like that personally. The other thing is, like I said, if they have Cushingite features, that sort of thing, and then I've seen case reports of there are sometimes drug interactions that can potentiate or increase the effects of some of the inhaled steroids, as far as I know. But like, again, those are less common. So because it's the problem is asthma is very common, and COPD is very common. So if we're talking about all patients with asthma or COPD, if any of them needs any kind of surgery, I think it would be too much. But those who are currently getting admitted to hospital or on daily steroids, inhaled steroids, and getting a lot of repeated doses of systemic steroids for exacerbations, those are the ones I worry about, the higher risk ones. But most patients with mild COPD or asthma, I don't usually do any assessment of HPA axis before surgery. And I'm interested to see what everyone else does too.
Thank you. So Dr. Kalan has to leave. He has to see a patient. We are in the evening, but Dr. Ahmed has an early evening, and Dr. Kalan is in his midday in UK. So thank you so much, Dr. Kalan. I think it's really been an enriching experience. Thank you for joining us. Thank you for sparing your time for this. Any last words from you, sir, before you leave?
Thanks a lot. It's a privilege and an honor to be here. I finally met Dr. Ganpati also. I've seen his pictures only. And Om, the beard suits you. Keep up the good work. And Saurabh's session was excellent. And I probably need to learn from Ahmed about the technology part of it. I'm totally naive. I probably can't even, change the light bulb at my home. So thank you. Thanks a lot. Okay. Cheers.
Thank you, sir. Thank you. So moving on to a very topical and relevant topic to both Dr. Ganpati sir and Dr. Saurabh. We'll start with, sir. What has been your experience regarding the use of glucocorticoids currently in the second wave of COVID-19 pandemic? And as an endocrinologist, what are the consequences that you are really looking for? And to the audience who's listening to this, because this is extremely relevant, what are some key take homes they should really take while dealing with such a case?
I think there has been, almost all the patients are having hyperglycemia to the extent that some of them, maybe one or two even developing BKAs also. So that's the what do you call the side effects of using glucocorticoid. But when we have to give it, of course, we treated them with the basal bolus, and in some we had to use even the insulin infusion, both the combinations, in fact, in them. And then maybe because of this, we are having an increased cases of mucor. I think around 5-6 days back, we had 5 cases of mucor on a single day. So that's a big number actually, because normally we see 4 or 5 in one whole year, and this we saw in a single day 5. So telling that probably this is also added to the development of mucor. So I think we'll see what happens is, yeah, just hyperglycemia is not producing this problem actually. Maybe the ketoacidosis plus the hypoxia-induced metabolic acidosis is actually producing that, with the increased ferritin levels also probably has caused the mucor. So these are the two things. And of course, people are coming now for follow-up, and some of them are newly diagnosed during the time, and many of them, of course, have recovered from that, who had hyperglycemia, the stress-induced hyperglycemia. Then some continue to be on the anti-diabetic medications also, telling that probably the COVID has done some damage to the pancreatic beta cells. So we have found all types actually, you can say. We haven't come across anything like an osteonecrosis because the dose used are very high. We haven't come across as of now. Maybe we may get it, but that's one thing. Similarly, the eye changes, the paniculitis, pancreatitis, etc., we are not yet come across.
Dr. Saurabh, what's your experience been with steroid use from an endocrinology perspective? In current scenario?
Sir, in current scenario, as sir already mentioned, we are getting quite a good number of patients who are presenting with very high blood glucose levels. And in many of them, we had to use glucose infusion, insulin infusion to control blood glucose levels. And we are using the doses of NPH and regular NPH doses of 60 BD and even regular doses of like 45, 50, we are using in many patients. And as sir said, osteonecrosis, we have not encountered a case of osteonecrosis. Probably, I think high dose required for a long duration of time is required. In COVID-19, we are not using steroids for that longer duration. Most of our, in our institution, at least we are using steroids for as low duration as possible. And another thing is, in the first wave also, in the first wave of COVID, we gave pulse steroids to few patients. There was work of pulse steroids at that time. Actually, people started advocating the use of pulse steroids. We gave around 500 to 750 mg of methylprednisolone per day to many patients of COVID with the evidence of cytokine storm syndrome. And in those patients, what we had seen, the mortality increased, especially the infection with Aspergillus. Secondary infection increased. And in the first wave, we encountered 4 patients of mucormycosis. And this is from first wave. And we have also submitted this data for publication also. 4 patients of mucormycosis in the first wave also. But in this wave, the number of cases of mucormycosis is increasing at a rapid pace. And majority of the patients who are presenting, they are having blood glucose in the range of like 400, 500, 600. Very highly uncontrolled blood glucose levels. And recently, we had 2 patients of mucormycosis who never got admitted to the hospitals, and they were on home isolation. They had COVID, they had diabetes, but they never received steroids. So probably it's COVID-related something. Immunosuppression is also playing a role in addition to the acidosis part, high ferritin levels, hypoxia, and high blood glucose levels.
Yeah. So yes, we saw quite a few in the first wave. After the first wave, also we saw a lot of mucormycosis in our state after the first wave, and I fully endorse your point that interestingly, we have seen a lot of home isolated patients on steroids developing mucor. We also seen patients who never received steroids but had poorly controlled diabetes and developed COVID who developed mucor. So I think to your point that I think hyperglycemia is the rate limiting step here. Dr. Amit, have you encountered in Kuwait mucormycosis post-COVID?
No, I was very surprised to hear about mucormycosis in India. In fact, just 2 months ago, we had a talk about diabetes and COVID-19. And as part of my talk, I talked about mucormycosis as an example of an infection that is more common in patients with diabetes. But I didn't realize that this is something that you were seeing in patients with COVID. Of course, our population is much smaller here in Kuwait. The number of people is smaller. So that could be why there is a difference. But we've definitely seen a lot of patients with severe diabetes, either known to have diabetes or suddenly newly diagnosed diabetes that we don't know if, COVID just made more obvious. It was maybe milder, and there are some hypotheses about COVID itself causing diabetes. But despite that, I think our number is probably much smaller than yours. So we haven't seen this. It must be very rare. We do have one central hospital for COVID-19, which is different than the hospital I work at. So they see a much larger volume there. So I'm going to ask them now about that. But as far as I know, we haven't seen cases of mucormycosis. I haven't seen myself in our hospital now.
So, mucormycosis has just been now declared an epidemic, parallel epidemic in India.
Wow.
Officially. So yeah, that's level. So I think that's the end of our questions. I think we answered most of the questions that were there in the chat boxes. So we have one question. I think Dr. Saurabh, if you can answer that in the chat box. This is from Dr. Raj Mohan. Patient was on deflazacort 1 milligram for close to 10 years. It was changed to Predmet. I think it was more of methylprednisolone 4 milligram. She developed adrenal insufficiency. Is it possible? Is it, it was deflazacort to methylpred, and then patient developed adrenal. So do you think that this patient should be put on some other steroids, or would you like to check the axis or anything like that? The audience question. So you can, yeah.
6 milligram of deflazacort is equivalent to 5 milligram of prednisolone, roughly. Right. So definitely, if we consider equivalency of steroids, we had replaced, the patient was given 4 milligram of prednisolone, which is quite a higher dose as compared to 1 milligram of deflazacort. So that patient should not develop adrenal insufficiency per se, if we talk of, because this potency is calculated on the basis of the potency of the steroid component to cause hypothalamic pituitary axis suppression. So, but the potency in terms of effect on liver, effect on other organs differ from steroid to steroid. But this is typically, we have calculation. So ideally, the one thing, methylprednisolone does not have mineralocorticoid activity. But deflazacort has some mineralocorticoid activity. So this is one difference. Probably if the patient developed adrenal insufficiency, it's unlikely. We should also look for the other cause of adrenal insufficiency in such patient, that he might not be having primary adrenal insufficiency.
Right.
Along with it.
No, maybe the patient in addition had some acute stress or something, and that could have led to that.
Precipitated.
Yeah, precipitated that. Because in fact, the dose of methylprednisolone was even higher than what he was using with deflazacort. So intervening stress probably precipitated. It's just coincidental when you are switched, it happened.
Right. Great. So I think, yeah, that answers the question from the audience. So once again, just to reiterate, our kind sponsors today have been SAMARTH Life Sciences, and the makers of oral hydrocortisone, which is available as Hyzon tablet. So those who are new to this, oral hydrocortisone is available in India, and as we discussed, it's a very useful medication to use in patients with exogenous Cushing with tertiary adrenal insufficiency. So once again, thank you to Dr. Kalan, who had to leave a little early. Dr. Ahmed, thank you so much. Really nice meeting you after a long time, and it's a pleasure. We hope to see you in more conferences in India. Since we're doing virtual, I think someday we'd like to really invite you to India for a personal meeting as well. Dr. Ganpati sir, thank you so much. Thanks again for joining us and for making this happen. And we always learn a lot from you, from your experience, from your teaching. And I think, it's really been fascinating. Dr. Saurabh Arora, once again, fantastic talk. I think you covered everything, that had to be covered on exogenous Cushing. And I think, especially students of endocrinology listening to this would have really benefited a lot from this. So thank you all. for a pleasant evening, and we hope to. This series is going to continue. The next batch will be coming up soon. We'll keep you posted. So the adrenal medicine series is really going to be interesting. So I hope you join us for the next session as well. So any word from the SAMARTH people, the organizers?
Yes, sir. I'd just like to take 2 minutes. I think it has been a very engaging session today with a wonderful presentation, excellent discussion among panelists on the same. Closing remarks have already been made by you, but I'm sure that our panelists and delegates will